Good afternoon, everyone. My name is Bhavisha Patel, and I have been tasked today to talk about immunosuppression and L-Thrombopag treatment in treatment-naive severe aplastic anemia. Where are we 5 years from the initial description of its efficacy? Before I start, I would like to thank the AAMBS Foundation for inviting me, for putting together this meeting, and also our hosts, Dr. Scheinberg and Dr. Shimamura, for extending an invitation to talk today. Here are my disclosures. We did have a CRADA agreement previously with GSK and then Novartis, who provided research funding for the clinical trial, whose data I will be presenting today. So as many of you know, a phase 2 study to assess the efficacy and safety of L-Thrombopag added to immunosuppression was initiated at the NIH in 2012, and the primary endpoint results as shown here on the slides was reported in 2017. Compared to a historic cohort treated with immunosuppression alone at the NIH, we showed that the addition of L-Thrombopag improved overall response and, more importantly, complete responses at 6 months. And this landmark study led to the FDA approval of this regimen in November of 2017. And in the last year, there have been 3 seminal papers that have been published that really expand our knowledge on the efficacy of this regimen and also describe the long-term outcomes which are important in patients who are treated with immunosuppression-based regimen in patients who receive, in addition, the L-Thrombopag. So here are the 3 papers that I'll go over, but most of my talk will focus on the last one here, focusing on the long-term outcomes. So very briefly, since my colleague has already gone into much more detail about the RACE trial, I wanted to bring this up just to mention that in patients who were 15 years and older, this randomized controlled trial showed that the addition of L-Thrombopag to immunosuppression resulted in higher rates of responses that were achieved more rapidly and were also more robust when compared to treatment or control arm in which the patients received immunosuppression alone. And these results were really encouraging and confirmed a report from 2017 that I just went over. And much of the talk prior to mine had been, and discussion had been around pediatric subgroups. So I won't spend a lot of time, but I will mention that we had performed a pediatric subgroup analysis from our phase 2 protocol where the patients were treated with immunosuppression and L-Thrombopag. This was a retrospective study where we compared 87 subjects who had received immunosuppression alone to 40 who had received both. And in contrast to what we observed in adults, we found that there was no improvement in hematologic responses in children that were 18 years and younger. And the lack of efficacy was particularly prominent in children who were less than 12 years of age. In the adolescents, although not statistically significant numerically, you could see over here that the addition of L-Thrombopag may have resulted in slightly higher response rates, but you could see that the numbers are small, so this cannot be definitively concluded. Perhaps the difference in responses between younger children and adolescents hint at underlying differences in the biology of the disease that continues with age, because as you will see, the long-term outcomes are really more common in patients as they age. And RACE trial did include patients between 15 and 18 years of age, but the numbers were really too small to really see if there was any benefit in this group. When we looked at relapses, as you know, historically in immunosuppressive treated patients alone, relapse is a big problem. It occurs in 30 to 40% of the patients. We found that there was no difference, maybe slightly higher in L-Thrombopag group, but this was not statistically different. Conversely, when you look at the overall survival, we saw that the L-Thrombopag treated group performed better than the children who were treated with immunosuppression alone. I don't think this reflects L-Thrombopag therapy alone, but also improvement in supportive care and second-line treatments, including second immunosuppressive therapy and also transplantation. As you could see, many of the patients included in the immunosuppressive group were actually treated in the 1990s. So the era of treatment was much different. And lastly, when looking at clonal evolution, which is the most dreaded complication in patients who are treated with immunosuppression, we saw that this was not increased with the addition of L-Trombopag. And this was true of all clonal evolution, and more specifically, high-risk clonal evolution, which is clinically probably the most important because it results in poor overall survival and poor outcomes. And in our protocols consecutively, since initial time, we have defined high-risk clonal evolution as diagnosis of myeloid malignancy based on morphology or having cytogenetic abnormalities in chromosome 7 or complex cytogenetics. As we know, with TPO mimetics, there's always a concern of clonal expansion, not only of cytogenetic abnormalities, but also pre-existing somatic mutations. So we try to look at that in our subgroup analysis, but as you could see, there were very few children who had somatic mutations detected at any time point. And when we looked at the type of somatic mutations, these are the bad players that we know from previous publications. So we saw ASXL1, ATRX1, and RUNX1. We did not observe a lot of CH or chip-like mutations like DNMT3A, TET2. Unfortunately, the numbers are too small to really correlate with outcomes, particularly clonal evolution. There were many smaller reports that I found that specifically looked at L-Trombopag in children, but one I wanted to mention was the one that came from St. Jude's Children's Research Hospital, where they retrospectively looked at patients who received L-Trombopag with immunosuppression or immunosuppression alone. And even though the numbers are slightly smaller than what we had in our analysis, they came to the same conclusion that it did not add to the responses achieved by immunosuppression alone. So here I'm going to move on to the long-term outcomes. A total of 178 patients treated with immunosuppression and L-Trombopag on our phase 2 trial since the initiation in 2012 were included in this analysis, and the control historical group was 102 patients, the same patients who were used in the 2017 analysis. And median follow-up at the time of the reporting was 4 years. First, we looked at relapse, and relapse was no different than what was observed in immunosuppression alone. And this was a little disappointing because we were hoping that the initial hematologic improvement would result in durability, but unfortunately, this was not the case. And as you could see, at median time of 4 years, the relapse rate in the L-Trombopag treated group was 38%. I've put in the definition of relapse over here on the right that we have consistently used, but as you can see, this is still quite broad, and some of it is subjective and depends on the trend of the blood count decline and how quickly the blood counts decline, and also that there are no other reasons for the decline in blood count, such as having concomitant infection. What was interesting in the L-Trombopag treated group is that relapse occurred at 2 distinct time points, and both of these coincided with adjustments or discontinuation of the medications. So as you could see, the first set of relapses occurred shortly after 6 months when the cyclosporin was lowered to a maintenance dose in majority of the patients, and L-Trombopag was discontinued. And I do think that, you know, these relapses occur so briskly between 6 months and 1 year was partly due to L-Trombopag withdrawal. And then the second set of relapses occurred when the cyclosporin was discontinued after 2 years. When we assessed for risk factors or predictors for relapse, we found that older patients were at significantly higher risk of relapse, and this continued to increase as they age beyond 40 years of age. Looking at the predictors of overall survival, we found that patients who were non-responders had poorer outcome than the patients who did have response to initial therapy. And unlike what we had reported earlier with immunosuppression treated patients only, there was no difference in survival when we looked at the robustness of response. This is because even in the era of L-Trombopag, they tend to be much more robust than the partial responses that we had seen with immunosuppression. And interest was not impacted by having a relapse. And this really affects both second round of immunosuppression. And here I wanted to pivot a little bit and talk about our ongoing efforts at the NIH to prevent relapse. So here we're looking at sirolimus, which many of you know is an mTOR inhibitor and a tolerogenic agent. And we're looking at it in a randomized fashion as relapse prevention. So patients who are on low-dose cyclosporin with stable blood counts, either from our initial protocol at 2 years or patients who have relapsed and now have stable blood counts would be randomized into either sirolimus arm where they would receive 3 months of sirolimus or control arm where they would stop the cyclosporin. And then the endpoint assessment would be at 2 years for relapses in both arms. We're currently accruing. We're a little over halfway done. It's too early to really say one way or the other, but we're hoping that we'll continue accruing and have the answer soon. So with that, I wanted to move on from relapse to clonal evolution. So clonal evolution, all clonal evolutions, both high risk and low risk, and I'll define low risk just in a moment, occurred in about 15% of the patients in this trial. Of them, 6% of them had high risk clonal evolution. And as mentioned before, the definition is listed here at the top. And this was no different than what was observed with immunosuppression treated patients alone. What I will mention is that the timing of evolution was much earlier in patients with L-Trombopag, and this is something that we had observed in patients who were treated in refractory setting alone. We do think that this is likely due to expansion of pre-existing clones by L-Trombopag, which is a stimulating agent to hematopoietic stem cells. Low risk evolution, which is defined as isolated chromosomal abnormality without any morphologic evidence, occurred in about 10% of the patients, and about half were transient, and the most principal or primary cytogenetic abnormality was deletion 13q. There was no change in peripheral blood counts at the time of evolution. Rather, these were picked up at protocol-mandated bone marrow biopsies and cytogenetic evaluations. There was no progression of these patients to myeloid malignancy or high-risk evolution to date. When we looked at predictors or risk factors for clonal evolution, we found that age again was one of them, and having achieved a higher absolute neutrophil count at 6 months, also predictive of clonal evolution. And both of these things, I think, has the underlying theme of having myeloid lineage-biased hematopoiesis. Survival, as you could see, is not impacted by having low-risk evolution, but patients who have high-risk evolution do perform much poorly and should be treated aggressively. Their primary treatment is transplantation. I wanted to bring this up from the RACE trial because this question still remains whether L-Trombopag expands the clones that may or may not be present at baseline. As you could see in this study, they nicely followed the somatic mutations longitudinally, and even though there is increase in frequency of somatic mutations from baseline to 6 months, this was no different in patients who were treated with immunosuppression alone versus those who were treated with immunosuppression and L-Trombopag. And with that, I would like to conclude that the addition of L-Trombopag to immunosuppression improves hematologic recovery in aplastic anemia. And this was confirmed again with the randomized controlled trial RACE. Children, particularly younger than 13, do not benefit from L-Trombopag addition, but the efficacy in adolescents, I think is still, the verdict is not out. Maybe these adolescents will behave more like young adults. A dedicated analysis, subgroup analysis, or maybe a study would better shed light to this question. Unfortunately, older age is a risk factor, both for relapse and clonal evolution, and these patients need to be monitored very closely for both of these long-term complications. And again, with the data that Grace provided and our long-term outcomes analysis, we have shown that high-risk clonal evolution is not increased with the addition of L-Trombopag. And with that, I want to thank again to the audience and everyone who is listening, all of our patient participation, our wonderful team led by Dr. Neil Young, my colleague, Dr. Guark. I do want to acknowledge Dr. Scheinberg and Dr. Townsley, who started the initial work with L-Trombopag, our advanced practitioners and nurses who keep the clinic going and patients flowing, and our rest of the statistic and laboratory team who do wonderful correlative work in aplastic anemia and keep us informed. Thank you.
So it's my pleasure to introduce Dr. Shinji Nakao from the Department of Hematology at Kanazawa University Hospital, and he will be speaking to us about romoplastin therapy for aplastic anemia.
Thank you. I'd like to thank the organizers of this special meeting for giving me this wonderful opportunity to present our findings. So I'm going to talk about romoplastin therapy for aplastic anemia. These are my disclosures. So why is ROMI needed for the treatment of aplastic anemia? So although the treatment of, with EPAG is effective in many patients with refractory SAA, as previous speakers introduced, approximately 60% of such patients respond to EPAG either partially or they do not respond to it at all. So it is well known that some patients with refractory ITP who do not respond to EPAG can sometimes be successfully treated by ROMI. As ROMI binds to a different side of the TPO receptor than EPAG, so it may exert a distinct stimulatory activity on hematopoietic stem cells. So Brigitte and his colleagues from France, the first questioned this issue by retrospectively studying the 14 patients with SAA, 57% of which had been previously treated with EPAG. And the median dose, median of the maximum dose they use is 9.4 microgram per kilogram. And they found improvement only in one of the 14 patients. On the other hand, Dr. Jong-Wook Lee and his colleagues from Korea studied the effectiveness of romiplastin in patients with refractory AA. And the weekly administration, weekly injection of ROMI, 10 microgram per kilogram, resulted in a recovery of platelets in 70% of the patients. And they also confirmed the safety and the increased efficacy of 20 microgram per kilogram of ROMI. Inspired by the Korean study, we and Korean colleagues conducted a phase 2 to 3 clinical trial to assess the efficacy of romiplastin in 31 patients with refractory aplastic anemia. And approximately 80% of patients responded to ROMI, regardless of the severity of the disease. The key point of this clinical trial is that the dose of ROMI was increased to the maximum dose, 20 microgram per kilogram per week in almost 60% of patients. And it seems that the use of the higher dose of ROMI is critical to obtain the good response to ROMI. And one may suppose that the patients who were successfully treated with ROMI may also respond to high dose of EPAG, which is a 100 milligram per day, which is approved by Japanese government and is equivalent to 200 milligram per day in Caucasian patients. And this patient relapsed with pancytopenia after withdrawal of ROMI and failed to respond to EPAG and became RBC transfusion dependent. But she showed a second response to ROMI, 20 microgram per kilogram. So that's suggesting that this high dose of ROMI, at least this side of this dose of ROMI, have a more potent effect on hematopoiesis than 100 milligram per day of EPAG. We also investigated the effectiveness of ROMI in 21 patients with refractory anemia who failed to respond to EPAG. The overall response was 76%, and 50% of 14 patients with SAA also responded. And in addition to our report published in Leukemia, another Japanese group reported the effectiveness of ROMI in patients, in 10 patients who were refractory to EPAG. And their response rate was 70%, similar to our study, although only two severe AA patients were included, and one of which responded in neutrophil. And this is a typical good response in a patient who failed to respond to EPAG. And this 66-year-old woman with moderate aplastic anemia was initially treated with EPAG and cyclosporine, and her platelet counts increased from 70,000 to 50,000. But it did not further increase during the next 15 months. And 1 month after, 1 month after switching to ROMI, her platelet counts increased to 80,000. And after treatment with ROMI, in almost 1 year, her platelet counts increased more than 500,000 like this. And after the ROMI was stopped, the platelet counts fell to 170,000, but it thereafter stabilized and almost for 1 year without the need to restart ROMI. We observed the most striking effect of ROMI in patients with late donor type, late graft failure after allo-BMT. This patient developed a late donor type graft failure after 9 months after allo-BMT, and failed to respond to EPAG for 9 months. And the attending physician was therefore planning to carry out a second transplant. However, the switching from EPAG to ROMI markedly improved her paracytopenia, and her platelet counts increased more than 200,000 in 1 year. And this patient also developed the donor type late graft failure in 7 months after BMT. And he also failed to respond to EPAG that was given 7 months. And after switching to ROMI, his platelet counts gradually increased. And in 16 months, his platelet counts surpassed 500,000. So these 2 patients were able to avoid a second transplantation. And the ROMI is now being tapered in order to achieve the ROMI-free remission. So based on this experience, we are now using the 2 different TPO-RAs depending on the condition of the AA patient. The EPAG for AA patients, EPAG is recommended for AA patients who prefer an oral medication to subcutaneous injection due to difficulties in attending a hospital once a week, and who suffer from severe iron overload. And ROMI is recommended for AA patients who are refractory to EPAG and are intolerant to toxicities associated with EPAG, so such as skin discoloration and liver injuries. And also those who do not care about making frequent visit to the hospital and desire more potent hematostimulatory activity than EPAG. So finally, let me touch on the issue of cure of refractory aplastic anemia in patients treated with TPRAs. So hematologic remission is maintained for over 1 year after stopping treatment in approximately 20% of patients with refractory AA responding to EPAG or ROMI. The mechanism underlying the cure of AA is unknown. The selective expansion of hematopoietic stem cells that acquire a survival advantage may be induced by TPRA. This is a typical clinical course of a patient who achieved a cure of aplastic anemia. This woman was treated with ROMI alone due to the poor general conditions, despite the patient has a very severe aplastic anemia. And she responded to ROMI alone nicely. And after stopping ROMI, she maintained remission almost 4 years with normal blood cell counts. When we studied her leukocyte for the presence of HLA class 1 lacking cells after the hematologic recovery, there were HLA class 1 HLA-B4-TO2 lacking leukocytes in the granulocytes, monocytes, in B cells and T cells. So this is probably why the patient did not require the immunosuppressive therapy to obtain remission of aplastic anemia. However, in addition to the presence of such escape clone, the patients, some other mechanisms need to be present to maintain a therapy-free remission and after TPO-RA therapies. So this cartoon shows how megakaryocytes regulate the hematopoietic stem cells that are reported by Dr. Toshio Suda from Singapore. So megakaryocytes secrete TPO and C-type lectin-like receptor 2, CLEC2, to regulate the hematopoietic stem cells at G0 level and stimulate the hematopoietic stem cells. And once this kind of megakaryocyte niche is firmly established or reconstituted by long-term TPO-RA therapy, the megakaryocyte circuit may start running to stably support the hematopoiesis of AA patients. And after, the long-term TPO-RA therapy. So this is the summary of my today's talk. So ROMI is effective in 70% of the patient with AA refractory to EPAG, and it allows a transplant recipient with a donor type aplasia to avoid a second transplantation. As two kinds of TPRAs, namely EPAG and ROMI, have both advantages and disadvantages respectively. They should be used appropriately depending on each individual patient condition. The evolution of hematopoietic stem cell to acquire resistance to an immune attack, as well as the reconstitution of the megakaryocyte niche, may positively contribute to the therapy-free remission induced by TPO-RAs. These are my young colleagues at Kanazawa University. Thank you very much for your attention.
Everybody has any questions? Yeah, one in the back. Go ahead.
Thank you very much. That's a wonderful talk. For the, how do you think about the differences between the response to eltrombopag and the seemingly enhanced response to higher doses of romiplastim? Do you think it's a matter of dose, that you can drive up the dose and it's just, like you said, more potent?
Actually, I don't know what's happening in those patients who either low or high dose of, you're asking the effect of ROMI or generate TPRA? Yes, and as I introduced in my last slide, the higher dose of ROMI may probably be able to repopulate the megakaryocyte. And those firmly established the megakaryocyte niche, and then in turn the megakaryocyte may stimulate the hematopoietic stem cells. So that's my own hypothesis. I don't know whether it's true or not.
And just to make a comment, I mean, the romiplastin studies, they often include moderate aplastic anemia, not just severe. And for the eltrombopag data, that's only severe. When they report it as severe, there's data on moderate as well. But for the ROMI studies, it has been lumped. The AA, the moderates, the non-severes with the severes in the trials, correct? It's not only for severe.
Both effective for, effective for both severe and non-severe.
Correct. And right. So
Right.
The 50% that you see with eltrombopag in those trials, they're mainly purely severe aplastic anemia. There is a separate trial just for moderate aplastic anemia, but they don't combine both populations, as in the ROMI trials protocols. I have a question. One of the concerns with eltrombopag, given that existed in its development, was to giving these higher doses for a long period of time. And that seems what it's happening in the romiplastin trials in terms of clonal evolution. There was a concern, more than a theoretical concern, about clonal evolution in ultramopag, and attempts to abbreviate exposure, et cetera, were tried. You're giving romiplastin for quite a bit of time at high doses. What have you seen in terms of clonal evolution in this patient population?
Well, thanks for the very important question. We haven't experienced any patients who developed a secondary MDS among, I think, more than 40, around 40 patients with SAA. That includes both NSAA and SAA. And we are following the clonal analysis, somatic mutation analysis in only 3 or 4 patients on ROMI. And we haven't, and we are looking at one patient with ASX1 mutation. And unfortunately, the frequency a little bit increasing. But in other patients, we haven't seen any, all 40 patients, we haven't seen any patient who developed new somatic mutation or an increase in the pre-existing somatic mutation clone.
So no progression to MDS so far.
We haven't seen.
And that's in refractory, that's in the refractory setting.
Okay, yes, all refractory. And
I mean, that's a big difference with eltrombopag. And with eltrombopag, it occurs early. So if romiplastin is working roughly the same as we think it is, you'd expect to see it within 6 months. So you're not seeing it, 16%.
Yeah, you would see early with
refractory
eltrombopag.
setting.
Actually,
That's a big
yeah.
difference.
right, but Neil, actually, we haven't seen the secondary MDS in patients treated with EPAG either.
Okay.
So
maybe
there
that's
may be
a
some
bigger difference than
yeah,
just
the difference.
What about horse
due to
ATG?
difference.
What about ATG cyclosporin alone without TPO? What's the rate of clonal evolution?
ATG plus EPAG, you mean?
No, ATG cyclosporin
ATG
without
cyclosporin.
TPOs.
Well, that's a very important point. In general, the incidence of secondary MDS in Japan is around 5%.
Yeah.
And as Yoshi demonstrated in his presentation, the incidence of secondary MDS is much lower in Japan and Korea, which is probably due to the low frequency of HLA-B4002. We actually, no individual has HLA-B4002. So I have been wondering why the incidence of secondary MDS in Japan is so low, and Yoshi's study probably clarified the reason, the very low incidence of the secondary MDS.
Yeah, but that's a good thing. Obviously, I mean, you stop wondering. I mean, because Tom's paper was 40 patients. Right, and that you saw same number. So you have the same number of patients.
Shinji, I wanted to ask you quickly: is anyone in Japan or Korea looking at upfront romiplastin to substitute eltrombopag, just as initial treatment? I mean, if it really works better and is a stronger stem cell stimulator and restores the megakaryocytic niche, is there any study ongoing with Amgen or?
As a first line therapy, the effect of ROMI added to the ATG plus cyclosporin is going to be presented at the upcoming EHA meeting. And I cannot go into details, but almost 80% of patients responded to ATG plus cyclosporin plus ROMI.
Adults?
In adults, even though the use of ATG, the kind of ATG is rapid. So it may enhance the effectiveness of rapid ATG cross cyclosporin by 20 or 30%.
Yeah, a lot of people in Brazil are giving rapid ATG cyclosporin eltrombopag because we don't have horse, and people are not complaining so far. We have used it at our centers as well, and the pediatric population. I've been talking to 3-4 pediatricians who have given eltrombopag with rabbit. And from the top of my head, almost everybody responded, or nearly everybody. So it looks like that eltrombopag with rabbit might actually take some of that. We don't know. I mean, but your data that's going to be presented, and I spoke to Vallejo and Andrea Bacigalupo when we worked together a couple months ago virtually, and they are having the same, obviously anecdotal, but this needs to be put together formally and presented formally, et cetera, et cetera. So it's interesting. Yes, go ahead.
The cytokine receptors. Any evidence that it activates EPO receptor or GCSF receptor, which are structurally very close to thrombopoietin receptor?
Well, the site of binding of ROMI to TPO receptor is exactly the same of natural TPO, and it's as ROMI is a compound complex of IgG heavy chain and peptide. It cannot get into the cells. I mean, without the TPO receptors. That is different from EPAG. So as you know, the current evidence show that the EPAG's main effect is mainly mediated by non-receptor mediated, getting into the cells by itself. And so ROMI cannot do that method to stimulate hematopoietic stem cell because it can only activate the JAK-STAT or MAP kinase through binding to the TPO receptors.
Yeah, and it is a more potent agent, right? I mean, you're talking about micrograms versus milligrams, right?
Yes,
it is a more potent, it stimulates the pathway more potently than eltrombopag. In ITP, it doesn't seem to make a difference. In ITP, it doesn't seem to make a difference, but in marrow failure, we don't know. I mean, it's still evolving. All right, I think we should move on. Yeah, go ahead. Thank you, Shinji. All right, for our last talk, when we were putting this program together, Akiko was so worried about, holding you for lunch, dinner late, and we were trying to put two inherited marrow failure talks, one Fanconi, one telomeres, but we were not giving enough time. I just noticed that the transplant people had at least half an hour more than we did, but I'm just saying. Anyways, we were able to obviously get one in telomere biology, which is important. Fanconi will be for the next time. And we are late. Everything Akiko did not want is happening. So anyways, for our last talk, we have Dr. Rodrigo Calado, who is chair of the Department of Medical Imaging, Hematology, and Clinical Oncology at the University of São Paulo, Brazil. In São Paulo, Brazil, Ribeirão Preto is a great friend, colleague, collaborator, and he will tell us a little bit about some different approaches for telomere disorders.
Okay, so thank you very much, Neil, Phil, and Akiko. For I am probably hungry.
You're so used to saying Neil,
Phil and Akiko for this very kind invitation. Yeah, I know too that the bar is already open, and that's a very unfair competition. So I'll try to be as fast as possible. But the thing is that if you stay until the end, I'll show you how to elongate your telomeres and stay young forever. Okay, so to treat patients in the non-transplant setting, we have a few ideas of what we want to treat for these patients. So basically, the first thing is try to improve the blood cell counts, whether the patients have severe or moderate aplastic anemia, unilineage cytopenias, or they're transfusion dependent. But we also have to think of that these patients have a proclivity to develop MDS and AML, and we have to think of how to prevent that clonal evolution or transformation. And they also have manifestations in other organs. And we should think that this is an very important issue for patients with telomere biology disorders. And the transplant is not necessarily treating or approaching these issues. Maybe it's even further accelerating that. So in the big picture, this is what we have to think of when treating patients beyond transplant. I'm not going to talk much about the work from Danielle Townsley that just came, and she had a couple of drinks before entering the room. But she led this study using the danazol treatment for patients with telomere diseases. It was a total of 27 patients receiving 800 milligrams of danazol daily for 2 years. When we started thinking about the trial, we went up to the highest dose possible at the time, because we didn't have any good idea of how these patients were responding. And basically, the primary endpoint was the telomere length, and we were able to see that patients had telomere elongation using this method during the 2 years under danazol using qPCR. And that correlated also with a hematologic response. So back in Brazil, we set up a trial using nandrolone decanoate that is not oral, but it's IM, and maybe we can have less side effects, and that would be similar to what we were talking about, the trombopag and romiplostin. So we set up this study quite similar to what Danielle had, to a total of 20 patients, also seeing secondary endpoints, toxicity, and the efficacy in the blood counts, but also try to see the pulmonary function. So a total of 20 patients were screened. I tried to go fast here. 17 patients at the end were enrolled, and 2 were off study at this point because died of respiratory failure, the other one from intracranial hemorrhage, and other 5 patients were off study because either of adverse effects, or another one died from respiratory failure, another intracranial hemorrhage, and 1 went to stem cell transplant. So from the 17 patients, we had most of them had a TERT mutation. Only 3 didn't have. Couldn't identify any mutation. That one in these 3 didn't have a telomere biology gene mutation. We later found that he was heterozygous for a SMD9 variant, although he had short telomeres. And the median age was a little bit younger than the study from Danielle Townsley. But we also saw some telomere elongation, and here using a different method, using flow fish that was developed by Fernando Gutierrez Rodriguez. And we saw also some degree of telomere elongation, especially in the first year, and it was less pronounced in the second year of therapy. That correlated with hematologic response. At 12 months, 50% of the patients had hematologic response. In 24 months, 63% of the patients, you can see here in this graph, that also some of the patients who had pulmonary disease at the beginning also showed some improvement. This was quite interesting, that from the 6 or 7 patients who had pulmonary disorder at the beginning, or some degree of the lungs were affected at the beginning of the trial, during the 2 years, the DLCO was pretty much stable, but it went down after they were off therapy, which is quite similar to what Danielle observed to a few of these patients there in the trial. Although that's a small number of patients with pulmonary disease in our trial. The other thing, I think that Fernando showed a little bit of this, and we were concerned about how nandrolone could affect clonal hematopoiesis in these patients. And what we have here is that there is not a specific pattern. So we can see that 2 patients who had, let's say, the high risk mutations One is this patient with ASXL1 and a RUNX1 mutation. Both clones went down very rapidly during the nanolone treatment that we cannot explain. And the other one who had the U2AF1 mutation clone, it went up. And unfortunately, these are the two patients who died from intracranial hemorrhage. And one of them, the patient 15 here, or 14 here, he eventually developed MDS with a 20q minus chromosomal abnormality. But in the others, we really don't see a real pattern going on in these patients either. In terms of the diverse events, it was quite grade 3. We didn't have any grade 4 event, and the grade 3 was in a minority of patients, although for some of them we had to stop therapy, as I showed you, especially for the patient who developed depression. But it was pretty much similar to what we saw in patients using the danazol treatment. Grade 1 and grade 2 was about also 40 or 50% in the cases of transaminitis. So I'll just move on a little bit to potentially novel therapies for expanding hematopoietic stem cells in patients with telomere diseases. So we talked a lot about the thrombopag here, and that's interesting that we found that they expand pretty much the MPP compartment, not so much the HSCs. And this matches what happens to these cells because the TPL receptor, the MPL, is pretty much in humans, apparently, they are expressed only at the multipotent potential progenitor, not exactly in the HSCs. So probably that's where they have more of their effect. But we also have romiplostin, and we had small molecules like the stemragenin-1 from Novartis and the UM171 that I'll talk a little bit more to you today. So this is some work that we did first in patients with acquired aplastic anemia, showing that treating in vitro the cells from patients with aplastic anemia, we can really, in comparison to the MSO, we can really increase the CD34 population, especially CD38 negative. And when we look at more primitive populations, that MPP compartment, the HSC compartment, we can really see this increase in the compartment when the cells are treated with UM171, but not when they're treated with stemragenin-1, for instance. So we also try to see that how it happens to patients with telomere diseases. So we got CD34 cells from patients, from the bone marrow from these patients, and try to treat that with UM171. And you can see that it also increases the number of CD34 cells in the presence of UM171. The population that is CD34 but 45AR dim also is much increased, and especially the population that is EPCR positive also is almost 10 times increased, showing that these population in patients with telomere diseases, although they have a very small and limited compartment of CD34 cells, you can expand using these drugs ex vivo. This drug has been used to expand in clinical trials to expand ex vivo cells from umbilical cord blood for transplant, and are safe to do that. And maybe this is another way of expanding specifically these cells. We didn't see much of a function in like the telomere lengths. Apparently they are stable over time, but that's a very small period of expansion ex vivo. And we didn't see any effects on clonality or showing clones that abnormal clones that might respond better to that, to the drug. Okay, so in summary, in the study with the nanolone, we found that that was safe with minimal severe events, adverse events. It associates with telomeres elongation, hematologic response, and also we saw some stabilization in the pulmonary function. But there was no specific effect on clonal hematopoiesis in these patients. Each patient responded differently. And we have perspectives of novel therapies, novel molecules that can expand the hematopoietic stem progenitor cell compartment for these patients. And that might be something interesting to think of in the future. I think that some of the speakers today talked about the telomere biology disorder, the book that was edited by Sunit Agarwal, Sharon Savage, and also Kate Stevens from the team Telomere. And if you want to download from the QR code, it's available online, and that's a very important work from the team Telomere. And with that, I'd like to thank all the collaborators. I'm not taking too long here because you saw all these names before. I'll just add the name of Guy Sauvageau from Université de Montréal, who is collaborating in the UM171 project. So thank you very much for your attention. I'm happy to take questions before the drinks.
So we're open for quick questions. Anybody has to, there's one in the back and I have a quick one. Go ahead.
Nice work, Rodrigo.
Hey, Jichen. Hi.
I'm just wondering, for the UM171 study you did with the patient samples, the expansion of CD34 is very obvious. Have you tried to put this into the NSG mice at least?
How to
Can you repeat the question?
to xenograft?
Yeah.
Yeah, so that's what we are currently doing to
Oh.
do the xenograft studies. Yeah, that's a very good question. So for this, from Guy has some of these studies for the umbilical cord blood, and they do expand better. There are some differences in terms of the lymphocyte population. In the DMSO, you have more expansion of the lymphocytes, especially before 12 weeks. But that's what we're currently doing, the xenografts with these cells. That's a very, very important point, Jichen.
And of those patients who relapsed after you stopped the dacadurabolin, did you try putting them back on it and did they respond or?
Some of them did, some of them did not. So that's an important question because I think that we saw that on the Nanozole trial also, because some of them were really hard to rescue again after they were off nandrolone. Like for instance, the patients who died from intracranial hemorrhage, they had platelets below 10,000, and we couldn't rescue that anymore.
That was terrific. I just had a question. In Fanconi anemia, when treated with androgens, one of the side effects potentially is pileosis hepatis or other vascular complications in the liver. So my question was, when you described the pulmonary decompensation, was there any evidence that that might have been due to AV, because these patients are also at risk for AVM formation? Was that due to a shunting pathophysiology or was that a different cause?
So we did it. That's an excellent question, and I really don't know the right answer for this. But the vascular abnormality, that's quite an important issue there. But we didn't have any evidence for these patients that they have AVM, at least from the pulmonologist evaluation. That was not present from their point of view. And there was one patient here in the trial that was the most impressive. She got transplant from severe aplastic anemia when she was 15, I guess. And then eventually she developed characteristics of DKC. And her brother also developed aplastic anemia. She was double heterozygous for RTL1. They both were. So we didn't evaluate her peripheral blood counts, but when she came to us, she was transplanted elsewhere. When she came to us, she came because they were thinking of GVHD, pulmonary GVHD, that was ruled out by the pulmonologist. And then she came to us and we made the diagnosis. And she was using oxygen at home. And after starting that, the nandrolone, she went off oxygen. So that, which makes it's a very special case, and I cannot tell you much more about it because she was transplanted. Although they ruled out GVHD, I don't know how much you can really say that you didn't have anything else other than the telomere problem in her lungs. That might be also related to the transplant itself, but it was very impressive that she was off oxygen. But the vascular alterations, that's something that we really need to study better. That's a very good point. Marcin.
Excellent, thank you. So what's your hypothesis on the effect of testosterone derivatives on the telomere length? So in your study, nandrolone study, you have seen stabilization of telomeres or possibly even elongation of telomeres. Do you think it's more of an intrinsic mechanism of telomere elongation, or rather mobilization of progenitors that might have had longer telomeres that were already there, but you couldn't have captured them in periphery?
Yeah, these are the two possibilities that we might be inducing telomerase, and you have more telomerase in whatever the wild type allele that is there, and then you can get more telomere elongation. However, we really don't see, and Fernanda showed that earlier today, that the third promoter mutations that also increase telomerase activity, you don't see much of telomere elongation there. Although in cancer cells or in vitro, you can see that they elongate telomeres. So the other possibility, and the data from the danazol trial kind of suggests that, because when they're off, the telomeres go down, is that we are recruiting quiescent cells that had longer telomeres, or have more telomerase, or you can have more telomerase activity there, and these cells come to work and with more telomerase, and then they are not being recruited only, but you also they are having more telomerase activity, so they will keep their telomeres a little bit longer, or it will reduce their telomere attrition over time, because the other ones are pretty much completely eroded, right? So you change this balance in terms of cells and their telomere lengths, and that's what we see in the periphery. It may not be just one specific mechanism, but I think that the recruiting of quiescent stem cells is a very good possibility. Microphone.
One quick question from, looks like they were able to reestablish the connection here. It's a very quick one, and then I'll pass on to Akiko. Can you clarify, in the nandrolone study, did you say there were two patients? Sorry, it's from Parinda Mehta, who was asking this question. Can you clarify, in the nandrolone study, did you say there were two patients who had progression of a clone with one developing MDS? Is that correct? So you had...
No, yeah, there were two patients who had these, one that had ASXL1 and RUNX1 mutation, but the patient didn't have any evidence for MDS.
Did any patient had any developed?
The other one who had the U2AF1, he developed the 20q cytogenetic abnormality.
Okay.
Thanks so much. I just would like to thank Rodrigo. At this point, I think we're going to close the session and continue the panel discussion one-on-one with some drinks. So we'll proceed. Thanks so much.
Good. That was a great idea. Depends on how it's something very gradual, you know,